Welcome back to SME Symposiums. Thank you all so much for being here. This month, we are covering patient pathways in the NHS. I know we're still waiting for some more people to join, but we will get started. I'm going to be your host today. My name is Mohsen Salim. So first of all, just before we do jump in, for those joining us for the first time, I just want to briefly go over what it is we do over here at SME Symposiums. So SME Symposiums is a department of Study Medicine Europe. And what we've done is, for the last, I think, 11 months now, we've taken the initiative of making monthly webinars on important medical topics of all sorts. Really, the mission over here is to keep international students up to date on relevant and important information. Everyone is welcome, SME and non-SME students, and it is completely free for everyone. You will get a certificate for attendance if that's what you're here for, but you will need to fill in the feedback form at the end. I will send the link when we get to the Q&A. So today we're having two very, very amazing doctors with us, Dr. Coogan and Dr. Prab. And basically I reached out to them regarding something that was very near and dear to my heart, because when I was doing electives, one of the things I couldn't understand were patient pathways in the NHS. And basically by that, what I mean is all the different ways a patient can go through the system, in it and out of it. So multiple routes a patient can come into a system, A&E, AMU, GP referrals, so many different things, and how they rotate through a hospital. It's a very intrinsic system, almost like an organism on its own, and also the way they can get discharged. So I felt like learning this helped me a lot, and I really do hope it helps you a lot. Without further ado, I'm going to hand it over to Dr. Prab, who is going to be talking about patient pathways in the NHS. Thank you all so much.
Hello, can you all hear me? I'm not sure if I'm able to be heard.
No, we can hear you fine.
Great, so I'm just going to put the output up. Hi, so for those that don't know me, my name is Dr. Babisha. I'm actually a Study Medicine Europe student myself. I completed my medical master's degree in Bulgaria, especially it was Plovdiv. I started working in the NHS this year and working as an SHO clinical fellow. So it was kind of where I'm trying to figure out what I like to do and what I want to specialize in. So yeah, so I'm currently working on a general internal medicine ward, which covers A&E take and acute medical unit. So today we're going to talk about patient pathways, and it's really important to know how a patient has entered the hospital, because it's really important for their care, and then thinking about how they're going to be safely discharged. So we're going to cover understanding patient pathways, what is the journey through it, the purpose of why we have a start and end of patient's care, and also the process. So we also involve the involvement and responsibility. So what type of doctors are involved, who does see the patient first, and how they escalated or discharged home. And then Dr. Coogan is going to be talking about transfers, referrals, and discharge. So this is an overview. So hospital admission, it's when a person comes in contact with the hospital at first and needs medical care. They're then clerked, so that's normally in A&E. So that's where you get the terms take and then post-take. So it's the first point of information gathered by a clinician or a doctor about a patient's condition before they're admitted. And then we get medical action. So do we need advice from different specialities? Do they need to be transferred somewhere else? Do they even need to be transferred to a different specialized hospital? Such as burn, sometimes burn units are not in every hospital. And then we go on to their treatment. So what's their treatment regime? What's their care plan? And then onto their discharge, which is really complex. There's many different pathways that a person can be discharged, which Dr. Coogan will explain later on. So the definition is, it's the official definition, is the routes that a patient follows from the first contact of an NHS member of staff. So that could be, you know, when you walk into the A&E, if you drove there yourself, you get to this desk and they'll just be like, what's your name? Why are you here? Or from the ambulance will transfer the information. So then that's via referral. So that could be via your GP, or it could be just via ambulance, or which I'll come on to. I'll explain the different ways to the completion of their treatment and their discharge. So the primary information that is to be collected when a person enters the hospital is these ones, okay? It's their name, age, and gender. Their NHS number is really important. They need to be or have an NHS number. To get an NHS number, they need to be registered with a GP. So you need their GP details. They may have a hospital number, but if they're new to this hospital, then they'll transfer that information from the hospital, if they were at a previous one, onto this like application. Then if they have any next of kin, so emergency contact, that's important. And then also a good idea to collect is like the number of admissions that they've had in the last 12 to 24 months. And that is really important, depending, you know, if it's an alcoholic and, you know, he's only been admitted once in the last 2 years, that's kind of an indication that something else, it may not be just due to alcohol. I've seen people that have been admitted 36 times in the last 12 months, which could be due to drugs or alcohol, or something they've had a failed discharge, so something hasn't been diagnosed and they still have this ongoing problem. So that's really important. So admission, the first thing that you collect is the day and the date and the time. Because from the time they're admitted from the hospital, or from the time they enter the hospital, they have to be seen by a doctor within a space of 4 hours. It's really important. Sometimes I know hospitals are under so much pressure and shortage of staff, but that is the time limit for an A&E for a person to be seen. So the way that they can be brought into the hospital is emergency. So BFER is a little anagram for brought in by ambulance. It could be other ways of emergencies, maybe like ambulance, helicopter, or they have other services that are similar to ambulance. It could be elective, so it could be planned for them to come to the hospital, maybe for elective surgery or elective procedure, but they may need to go through A&E first to determine their status. It could be a transfer, so it could be, this happens quite a lot, a transfer from, we currently work at East Surrey, so we get loads of step downs from St George's, maybe patients that have been there for a long time and had procedures, but they've deepened conditions, so they've obviously got worse and they need extra hospital care, so they get transferred here. We also do transfers to other hospitals, such as Stanmore, if they have orthopedic problems, or we send them to St Heliers, which is more renal. It could be maternity, so if they're pregnant, that's kind of a big bold circle. And other ways that they could is probably just by self. Source of admission. So, you know, a person doesn't feel that well and they say, okay, I think I need to go to the hospital now. You know, the GP's closed and I need to get seen to right away. Or maybe the services 111 has advised the patient to go to A&E, or maybe 999, they just won't be able to attend, the ambulance won't be there for a long duration of time due to shortage, which has occurred during this COVID period. It could be via GP, so someone could have gone to the GP, acutely unwell, the GP thought, okay, this needs to go to an acute hospital and immediate care is needed. Or it could be A&E, so that just means sometimes patients are in the hospital and they may have like an outpatient scan or a checkup, or they're with a family that needs to go for an outpatient clinic, and you know, some people have collapsed and felt very unwell, so then they've been transferred to the A&E. Or maybe a family member has brought them in, even without the patient wanting to go to the hospital, a friend, or usual place of residence is very common. So this could be like a care home, a nursing home, assisted living, in a flat where there's a warden that looks after mostly the older people. And they felt like the patient is not doing very well, or the carer that comes to their house felt like there's something wrong and there's an infection or something. So they bring them in and they say, you know, this person needs to go to the hospital. Okay, so I'm going to go through a little bit about take. So that's what we discussed here, number B. So it's called clerking. So it normally happens within 4 hours. It normally goes green, orange, and then red. So green means that we're good for time. Orange means, oh, we're coming close to 4 hours. Red means that person's been waiting a long time and they need to be seen immediately. So I've got a little blank and then I've got out a filled one. The top tips, okay, for clerking is to write really clearly. Most doctors don't have good handwriting. It's really hard to read someone's handwriting if you like it's not clear. This clerking booklet goes all around the hospital with the patient all the time until they're discharged. So it's really important to get this information correct. If you don't know it, leave it out. Don't make anything up. Try to be really clear. Use a black pen all the time. You only use black pens when you start working. And despite how busy the hospital is take your time and flow through each patient really carefully and identical. You carry this booklet until, you know, until you go to post-take, which I'll come on to later. So you can always go back. It's not like you fill it out and then you're not able to add to it or something. So this one, you put normally you get a sticker. So I've put Snow White, and then their date of birth, and then their hospital number. So normally you can print out stickers. Every trust is different. Every booklet will be different. This is just a booklet from our trust. And we type in, just write your name, the date, and then the time. It's not when they were admitted, it's the time you see them, okay? So you just write your grade, a contact number if you carry a bleed or extension, and then we say, are they GIM, so general internal medicine, or elderly? So if they're below 75, they're GIM. If they're elder than 75, so elderly. So what is the main presenting complaint? So you always ask the patient, what brought you into hospital? Was it shortness of breath? Was it chest pain, diarrhea, vomiting, or just generalized pain? So there's like loads of options. Try to keep it quite simple. If they're being transferred, you just write transfer deconditioning, or, you know, step down from something. It's really important just to keep it really bold, really easy to see, and symptoms to go off. Okay. Then we go to the history of the presenting complaint. So at their age, their gender, how they're brought in, what their symptom was. So always ask them, so how long have you been feeling like this? Like, is this a new ongoing thing? Has this been going on for months, or is this quite new? Try to get as much information as you can. It's really important. If they're unable, if they're drowsy or not conscious, then try to get this information from a family or friend, call the next of kin. Was there anybody around? Ask the ambulance services if they can fill you in with just any information. You want to gain as much as you can so you kind of got an idea about the patient. So this is actually a real patient. I've obviously changed the details for, you know, reason. So this patient came in with vomiting and diarrhea. She was admitted just last week with the same symptoms, but she was just given fluids and then discharged. So that kind of sparked in my head that maybe they didn't diagnose her correctly, or they didn't find a real reason, or maybe this person has, you know, been given the wrong antibiotic or such that maybe it didn't cure her symptoms. She complains of hypogastric pain, so we do the scale. Then we can always write symptoms that they have and then symptoms that they don't have. It's really important. So she's got, you know, when you explain to the patient, try not to use medical terms, try to explain it quite simple and be very patient with them, because they're obviously not fond of being in A&E as well. And so just be very calm. So just be like, have you been coughing any blood? Have you got any cough, shortness of breath, or chest pain? Have you had any vomit in your have you had any blood in your vomit? Have you had any fresh blood or dark stools in the last week or 2 weeks? How is their urination? Is it painful? Is it quite regular? Do they wake up at night to urinate? Also important, are they able to eat and drink? She's unable to eat or drink because she keeps vomiting constantly. How is her bowel movement? So she hasn't opened her bowels for 6 days, but she's been having, diarrhea for the last 24 hours. She's unable to sleep. So, and medication, she's on a blister book, so it can be called a blister book or a blister pack. It's just good to know about her medications. Any other symptoms that she's not had. So I just completed that. We'll move on, not to spend too much time. So this is the second and third page. This is my favorite page of them all because past medical history is super, super important. It's really good not to use abbreviations. No one really knows what most abbreviations are. So except from COPD, probably, that's probably the most common one, but there's loads of abbreviations that can stand for loads of things. So I just really like to write it out clear and just write it fully because every doctor along the way will see it and they may have different ideas what different abbreviations are. Don't guess if you can't fill out every single box. Don't worry about it, just leave it blank and then maybe you can come back to it later on and find more information, or they can find it on later during their admission. So like I said, it's not a way for the drowsy or unconscious or not in a good state. Just ask family and friends to fill out as much as you can. So this is what I got. I write it out in full course. So type 2 diabetes, she's on insulin, so that's really important. Are they insulin dependent or not? She's got chronic kidney disease, so good to write their baseline of their urea or creatinine. And it's also a good idea to write what stage they are as well. If they got persistent AF, I know I use the abbreviation, but it's atrial fibrillation. Try to use what drug they're on or any medication that they use to control it. They've had a cerebral vascular accident, a stroke, and good to write the year. So you basically want to get as much information as you can. This could come from the patient, their family or friends, or you can check their GP summary, which normally has a summary of their diagnosis, any of their problems and their medication. So I filled out a little bit of that. They've had both COVID vaccines and their booster. I don't know if she's had COVID in the past or not. She wasn't able to say, so I left it blank. She's got a little bit of mobility problems. She can lose balance. She's got mild cognitive impairment. So, but she still does have capacity, to my knowledge at this point. But on the GP summary, it said that. So her main symptoms are gastro, vomiting and diarrhea. I didn't think that she was having any cardiac or respiratory problems despite having COPD. She had no breathing difficulties. So then we go on to her social history, which is really important. Most people don't say the truth about smoking and alcohol, which is fine. If they're a little bit reluctant, just leave it blank and ask them a little bit later on once they've warmed up to you. Most times, this always, when we come across patients on ward, it's always no, no, no. And then when I ask them, they're like, yeah, I smoke 50 cigarettes a day. And it's like, okay, we should change that. Okay. So she lives at home with a stick. She has POC, means package of care. So it just basically means when carers go to the house. This is TDS, so 3 times a day. She has an electric scooter for the outdoors. So it's just all this information, which is really good. Most of the time, people don't fill out all of it, so it's fine. It's just great to get all of it in, to get a general idea of what the patient's baseline is. So relevant family history, sometimes it's mostly nil, they don't know, but in this case, so I just put that her father may have died at colorectal cancer. It may be related, it may not have anything to do, but it's good to keep it in mind. About her DNAR, yeah, so her resuscitation state, if they are from a nursing home, care home, any assisted assisted living or community, they may have a community do not resuscitate form, so that's really important to put in case anything does happen, then at least, you know, it's there. We can make a new form for the hospital if they haven't brought it in with them. So she states that she has an allergy to penicillin. She states that she has diarrhea. Good to write it down. All these medications I gained from her. Well, she brought a couple of drugs in with her in her handbag, so able to write those down. It's good to write the dose and the frequency, because as much as that most of them are standard, people have sometimes different regime. You can check it on her. It says SCR on the bottom, which I've ticked, which is basically online where you can check their GP. Every trust is different, so please check your trust guidelines when you start working and how you can get this information. And then a recent EDS, electronic discharge summary. Some people call it TTO. It's different in every hospital. It's a bit confusing, but she was only discharged last week, so we can use that as well. And that'll be her most recent drugs, which will be really good to use. Okay. This page is good, so it depends what the person's coming for. You can focus on certain parts. So if they're really old, a frailty scale is pretty good to use. So she's mildly frail at this point. She needs help to do daily activity, like some daily activities. She has package of care, so carers coming to help her. She walks with a stick and she uses electric scooter. She can't walk that far. And then we do cognitive impairment. So this is quite good to know what state and what level they are. It's kind of nice that in the booklets everything is kind of explained, so you don't need to think about too much. So just about how alert she is. Can she remember where she is, the year? I sometimes ask, like, what's, you know, the Prime Minister, what year are we in? Do you know what month it is? Can mix it around so you're not asking them the same questions later on if you come back to it, just to check so they don't memorize the answers. And sometimes most of these answers are on their wristband, so try to mix it and use a couple of other ones just to make sure. Just how's their attention, so doing the months backwards or doing the week backwards sometimes, and then are they fluctuating in any alertness or cognition? So that's a really good thing to know if they have delirium, which is a very major sign of infection, especially in old people. That's probably the first sign of sepsis. Or is it cognitive? So is it quite kind of a long term? Is this their baseline, or are they completely fine? This one is a visual assessment, so it's good for people where you might think they might have like a neuro. I know I've put able, but she's more gastro, so not to worry about it too much. How is her, on the next page, so how is her general appearance? Some people, she looked quite pale, but she was alert and awake. We do have vital signs, so this should have already been done prior. So the nurse will tend to do certain tests before you see them and do this clerking, so you have some results to go off on. So we do her blood pressure, heart rate, respiratory rate, how's her GCS, her saturations, and if she's on oxygen, nasal oxygen, but she's on air. Her blood glucose is quite elevated, as you can see, and her temperature, she's 37.1, so 80 febrile, she's quite good. How's her hydration? She looks a little bit dehydrated, her tongue is dry, and she has skin turgor. Cardiovascular, so we're trying to look for heart sounds. If sometimes it's really hard to detect a murmur or not, so just leave it empty or just put a question mark if you're unsure of possibilities, and a consultant will come later and post-take and you can explain this to them. Auscultate, palpate, and percuss the lungs. So that's written like that. And then abdominal, so we want to do palpation, percussion, make sure that there's not pain or if it's soft. So she had a little bit of tenderness and pain in the hypogastric region, but she didn't have any rebound tenderness. I didn't manage to do PR on her. So then we can do CNS. I know this is wrong. I shouldn't have wrote NA. That's incorrect. So you just leave it blank because it is applicable. I just had no reason to do it for her. You can check her power. This is more neurological as well. Okay. And if they have any further notes, how is her, sorry, her speech, her gait, her walk, and is anything that she's dependent on. So the next one is, I know this seems really long, but you can always go back and forth, and it's quite important. So this is also my other favorite page, because we get to examine from head to toe, which is really, really important, because sometimes people come in with shortness of breath and they have a completely other condition going on once you strip them down and look at the body. So she has, when we examined her, she had some tenderness and erythema on her right toe. And also for females and women, it's really important to check their breast area and their top half, and any skin folds, because she did have some dryness, soreness, and redness and edema. And her tongue, you wanted to check her mucal, her tonsils, check her eye colour, any jaundice, how's her skin in nature, if there's any rash. So this all goes here. Especially another important one is like any precious sores, how deep are they? Could it be, quite severe, or DVT? Okay. So then the ECG, that should already be done by the nurse as well, but if it's not done, then get one done. It's always important to do an ECG. So this was the ECG actually from her previous admission that I saw online. This was her chest X-ray, so she's got COPD. There were just chronic changes, nothing. And then a CT abdominal pelvis was done in May. That was her last one. So I just wrote what the findings were on the report from there. The urine analysis, most of them came as nil, but we just put some results there. These are her blood results from admission. So as you can see, I didn't put the time. It's quite important to put the time of when these bloods were done. And I always like to put arrows if up or down, so that just gives an indication, like, is it within the range, is it lower or higher? It just kind of stands out. We know what we're trying to look for in this case. So we can tell, like, her hemoglobin is a little bit low, but it's not too low to be that worried. The potassium is 3.3. That's something that could be replaced, but it's not dangerously low. But maybe we should do another ECG and ensure that. Her urea and creatinine, so we know that she's got CKD. We know what her baseline is, so it's not acute. But we need to check what her she's got any AKI as well, so we can repeat that. Her CRP is raised, so that's inflammation or infection markers, and then also her magnesium is low, so something that we want to check, restore. Sorry, straight away. Her vitamin D is quite low. That's important, especially if she's got diabetes and if she's got a wound on her right foot, like, is it going to heal okay? And for her bone, if she's got any fractures. The CK, and we did some enteric pathogens, so no pathogen was detected. Okay, so this is the Genie page. Okay, so what do you think is going on? So you write some diagnosis. So she's got diarrhea, vomiting. I'm not really sure of the cause, but I know that it's causing dehydration. I know that on her right phalanx, a little toe, that there's an infection. It looks quite pussy. I know that she's got low potassium that needs to be restored, and low magnesium. And I know that rash underneath her breast that's quite red, sticky and dry, is probably into Torrigo. So this is my plan. Sometimes it's really fun to see what your plan is and then see the consultant's plan and see if you're even heading in the right direction. Most times, you are, most times things overlap, and sometimes you're just completely off the ball, which is fine, but at least the consultant may not see the patient straight away after you've seen them, so it's good to start treating them until the consultant comes. So I think we should do abdominal X-rays for her diarrhea and vomiting. Is there any obstruction? Probably not, but is there any overload or overflow? What is the cause for it? Because the CT abdo-pelvis, which I put in F, can sometimes take longer, so abdominal X-ray would probably be best. I also want to do a foot X-ray to make sure that her little toe is okay and then it's not damaging the bone. I want to give her a litre of fluids because I know she's really dehydrated. She's not been able to eat or drink for a few days and not very well. Need to give her some paracetamol, especially IV, because if she's vomiting then taking tablets is not going to work. And we should also have a gastro review, but they probably want to wait for the CT to come back. I probably hold her cloxamazole until her BMs are more stable, just in case they have any interaction. Give her some antiemetics, so it stops her nausea and vomiting. We can give that IV. So everything kind of should be IV at this point if she's continuing to vomit. We want to do a wound swab of her little toe, do a stool and C. diff sample to make sure that there's nothing going on in her feces that could treat, and then hold her diuretics, because obviously she's vomiting. We don't want her to lose even more liquid and fluids. And then also she needs a diabetic review because her BMs are just completely out of her normal range. So I estimate her discharge maybe 3 or 4 days after she's been admitted. She's under 75, sorry, and she probably need a gastro review and then a cardio one. So this is the consultant review. This happened maybe 2 hours after, or an hour and a half. I have copied I've literally copied what the consultant had written, but obviously in nicer handwriting. So consultant, they obviously do a full overview. They check everything themselves on the systems, on the previous notes. It's good to have all the information that you had just to make sure, but they sometimes find new information that we just haven't gone that deep into. So they realized that she's had a failed discharge. The stool is not tested because it's semi-formed, so it's not completely restored. There's no pathogens. Her symptoms previously resolved, but then they restarted, so she's collected this information. The wound around the little toe, possible fracture. Her BMs were really high and ranged from 17 to 18 today. And when she last opened her bowels, the consultant's done a full respiratory, cardio, abdominal examination. They've taken pictures of the wound and put them in Cerner. We've got a little past medical history box, little social history, what their immediate bloods were, and what the consultant thinks is going on is due to overflow and also an infected toe and fracture of the little toe phalanx. So this is the plan that the consultant makes. They want me to do a BBG, we want to check her ketones, her lactate is really important as well, and her pH, especially diabetes. We want to monitor her blood sugars, do the stool sample and C. diff sample, do an ECG because that hasn't been done yet. Every patient should have an ECG. They've also said hold the diuretics and then review in 48 hours, maybe hopefully she stops vomiting. Do a swab of the toe and also have an ortho review, which is quite important as well. I didn't think of that before. They probably want to see the chest X-ray, so let's get that done. Do a PR exam, I knew that was coming, and then an abdominal X-ray, a stool chart, so keep a diary of like how her stools are they improving, are they getting worse, is the frequency going up or down, what's the colour of it, and then start some antibiotics for the potential toe infection, especially because she's diabetic. We should treat it. So I normally do ticks, which I've done. Most doctors do these boxes, so half means that half of it's done, but it's not completed. So here it says it's on number 6. I've got half a box, so it means I've done the swab for the toe wound, but I haven't, the X-ray and the ortho haven't been done, so that's still pending. This is a GP, sorry, the consultant has said that I'll probably be able to go home a little bit earlier than I wanted, but we don't know. So sometimes the consultant's plan is different to the plan that the previous doctor has done, so you probably want to cancel it out and just see how it goes. So the divisions in A&E, so they could be either minors, majors, they could be a resus or observatory ward, means that the patient is there for 24 hours and then they get, after review, they can go home, so they don't actually get transferred to anywhere else. If the patient is severely ill, they're in PCU, high intensity unit or intensive care unit, and then they also have pediatrics, which is under 18. In these divisions, they can mix around within them during this period until clerking or post-take with the consultant has been done or has been done, yes. So intermediately, we do some jobs. So those jobs that we wrote, we can start doing them. We're also seeing other patients as well, so it's kind of like a multitask thing. So always keep a list of what you have, get speciality reviews if needed, and then await results. So like blood, or urine dips, or cultures. And by this time, after a certain time, you get an idea like where this patient needs to go and if they need to stay in hospital for longer. So they can be discharged if they're fit and well. Their problem has been solved and they don't need to stay overnight in the hospital. They just probably need to stay a couple of hours for some immediate treatment, such as fluids or some allergic reaction, but sometimes they have to wait for at least 12 hours after an allergic reaction, especially if they have another flare-up. So that could be in number 4 in divisions, not on the Respiratory Ward. But if they need some more investigations, they need to be seen. They're not fit and well to go home, they can get transferred to a ward. Normally get transferred to the specialty ward that they need, so the care. So if it's gastro, it'll be a gastro ward. If it's more cardio, unfortunately, the specialties like dermatology, I don't think they have a ward. I'm not sure in the do on this hospital either. But most of them come to GIM, or they go to AMU, and then from AMU they go to their specialty ward. Or if they need an immediate procedure. So if the person is, profusely bleeding, they need to get sent to surgery immediately, or they need to go for an OGD or endoscopy straight away. Okay, thank you. I'll answer any of the questions at the end. I think we're going to hand over to Dr. Coogan. So thank you so much, Europe. And if you want to ask me any questions, you can contact me.
Thank you so much, Dr. Just quickly before I do hand it over to Dr. Coogan, I just want to ask everyone, if you do have questions, please do put them in the Q&A. We will ask the presenters them at the end. I've already got a couple of interesting ones messaged to me. Thank you so much, Dr. Prab. I think everything was accurate except for the handwriting. I've shifted through hundreds and hundreds of case files. I've never seen handwriting that neat, I promise you. So, I think apart from that, everything else was bang on. But yeah, don't let that confuse you. I'll hand over to Dr. Coogan now. Thank you.
Okay, thank you.
Fantastic. You guys can hear me okay?
Yep, we can hear you perfectly.
Yeah, fantastic. Great. So my name is Coogan. I'm one of the internal medicine trainees year 3 at East Surrey Hospital. So I work with Dr. Prabisha in East Surrey Hospital. So firstly, I just wanted to thank Mr. Mohsin at Study Medicine Europe for inviting me to this webinar. I think it's very important in terms of these pathways of the NHS, because it may vary from different sort of hospitals in the country, but in terms of the pathways and how the patient sort of moves in the hospital from the time they come in till the time they get discharged, sort of fairly stays about the same, although there might be some variation between different hospitals. And sometimes, I guess, in different countries, it works fairly differently. But I'll be talking to you a bit about how it works here. Let me try and see if I can share the screen. All right. Right. Okay. So I hope you guys can see that. So yep. Fantastic. Great. Yeah. So I think this. Yeah. So this is sort of like what I think Mr. Mohsin is sort of fairly saying. I guess it's targeted to you guys who are, I guess, planning to come to work for the NHS or currently new to the NHS, and it's very important. Not just from what the talk that Dr. Prabisha gave in terms of how we sort of see patients, how we clerk them, and how we clinically assess them, but of course how they move around the hospital and how the different teams that get involved, which hopefully I'll be talking a bit more as we sort of go along, how they get involved in sort of this multidisciplinary team approach in terms of reviewing the patient and how we when they come to hospital, how we see them, how we treat them, how we manage them, and then hopefully how they get discharged home safely, which is the most important thing. So just before I go a bit, I guess a little bit deeper into things, sort of just my journey here. I am from Malaysia. I studied here in the UK. I did my medical school here. I did my foundation program, which is sort of fairly similar to sort of the first 2 years of just starting out as a doctor, where you move around different specialties. So I've been through obs and gynae, vascular, gastro. So I have a bit of experience, psychiatry, so a bit of experience in sort of different specialties in the initial parts as a junior, very, very junior doctor. But currently I'm sort of a junior registrar working at East Surrey Hospital, and sort of my day-to-day in terms of what I do is in a general internal medicine ward. So I normally see sort of under 75 patients, but because of how sort of busy things are, we also see over 75. But I normally sort of just deal with medicine specifically. And that's sort of my day-to-day job. So ward rounds in the morning, sometimes do clinics, but sort of during the on-calls, which is what you guys probably should know more about, is sort of how we sort of see patients. I'm involved in the cardiac arrest team. So anyone who develops a cardiac arrest, so I'm part of the team with the critical care outreach nurses, the anesthetists for airway and things like that. So that's a fairly important sort of thing to know about as well. And just about how previously when I was a sort of more of a junior doctor, it's about seeing patients, and I did a lot of those sort of clinical notes and how you sort of see patients and that booklet. But now in my sort of job role at the moment is for taking the referrals, which is, again, I'll be talking a bit more about how you sort of take referrals from patients that come in through A&E or from other specialties. We accept those referrals as well and review those patients and decide which is the best place that we need to put them in, basically, really. Yeah. So just picking up from what Dr. Prabhisha was talking about earlier, it was an amazing talk. So I'll be picking up from about transfers, referrals, and sort of discharges, and how basically we do it in the NHS sort of pathway, really. So just in terms of transfer, so I think Dr. Prabhisha did touch in this in quite detail. So I'm just going to have a brief run through about this. But yes, so most of our patients that sort of come in will come in through the emergency department. So whether or not they sort of come in directly or they get referred from their general practitioners. So usually it's routine or sort of semi-urgent referrals that sort of come in and they sort of see the GP, and if the GP feel that either A, they are too unwell and they should be seen in hospital, then sometimes if they have a family member with them, the family member can bring them to ED, or if they're able to, if they're able to call an ambulance for them then and there, if they're that unwell. Because what we sort of do hope our sort of GP practices are able to sort of, in a way, vet a lot of these patients, because they should have be able to do initial observations, sort of like heart rate, blood pressures, and just like a ops meter there, just to make sure that they're saturating okay and things like that. And hopefully they should be able to sort of, in a way, triage them and then send them to the emergency department if necessary. We also have our urgent treatment centers, which is sort of more of our out of hours. So I get a lot of these referrals when I'm doing sort of like a late shift on a long day in our sort of, for example, ambulatory care center. So for example, they give us a call about a patient that comes in with sort of a left leg swelling and they want to rule out a DVT. So they don't technically really need an acute bed. They don't need to be admitted to hospital. But what sort of we do have is an ambulatory care unit where they can sort of come in either the day after or 2 days after, and we have sort of dedicated slots to get ultrasound scans done, and they can come in for that. And our urgent treatment care centers are fairly good because they sort of work as like a mini clinic. So they do have, for example, if they're thinking it could be a clot in the leg, we don't sort of delay treatment just because we haven't got the scan done to confirm it. They are able to give either the sort of treatment dose injections of Clexane, which is sort of the blood thinning medication, or oral novel anticoagulants beforehand. So they're quite sort of useful in terms of how they manage the patient before sort of they come to us for the appropriate scans and a review thereafter. And of course, ambulance services. So of course, it's most of our emergencies. So for example, patients with really bad central crushing chest pains, for example, which you get a lot of, patients with an acute stroke, for example, so sudden onset, sort of weakness or dense weakness on one side, slurred speech or expressive dysphasia. So these are the ones, hopefully if they have someone sort of nearby, or if the patient is able to contact the ambulance, they should be able to sort of come to their home and hopefully bring them to hospital as soon as, because these are the patient, it's sort of what we talk about, the golden window. So in terms of time critical management, it's important they get the appropriate treatment at the appropriate time. So that's very important. And then sort of coming back to sort of what ED does. So yeah, so all these patients sort of coming through the front door. So I guess you can say ED is sort of our sort of triage service. They see all the patients that come in through the front door. So if any of you guys are sort of interested in sort of emergency department, so they deal with everything that comes through the front door, whether it be someone in urinary retention, someone with sort of diarrhea and vomiting, like what the case that Dr. Pravisha presented, someone with a stroke, someone who's come in with a perforation. So if that what sort of excites you, that's something that emergency care doctors do on a day-to-day routine basis, really. So they are the ones usually that refer to us. So for me, for example, I take the medical referrals. So they refer to me for any patient that they feel is appropriate. So this is what I mean for my second point, the referral to appropriate specialties. So the patient pathway in terms of where they which team they should go under. So just say, for example, a young female of childbearing age comes in with abdo pain, shouldn't really be under the medics. It should go either under the obs and gynae team or the surgical team, because the things that potentially, so this is what sort of the ED doctors train themselves when they review the patient, is where should this patient be placed, because that's the most appropriate thing. Because ED doctors usually make sure that the patients are stable, and of course, if they can be discharged, they'll discharge them with safety netting. But if they feel that these patients need to be admitted, then these patients need to go to the appropriate specialty. So coming back to that young lady of childbearing age that I was talking about, so it potentially could be an ectopic pregnancy with the abdo pain, potentially it could be appendicitis. So it's not really so much of a medical issue. It could be a surgical issue or sort of an obs and gynae issue. So that's important. So once they get referred to that appropriate specialty, if they've done their scans, they've done their investigation, bloods, for example, and they've ruled that out, and if they still feel that they sort of can't really figure things out and there might be some medical issue involved, then they usually sort of talk to me. And I guess I review the patient and see if there's any other issues that potentially could be contributing to a symptoms that potentially is not surgical or not sort of obs and gynae related. So that's very important, because the issues that what we usually face is, if once the patient gets referred to a particular specialty and they get accepted, it's very difficult to refer them to other specialties that if the patient requires that sort of input, which I'll talk about in terms of the referrals as well. But the key issue is always when we want to sort of transfer care or sort of ask other specialty to take over care, is always a bit of a difficulty sometimes. But that's the key thing about communication. So how we talk and sort of lies with all these different specialties is very, very important. I was talking a bit about our ambulatory care unit. So some hospitals may not have this, but usually we have sort of patients that come in from the medical point of view, because I do have this sort of on calls in the ambulatory care unit. So basically patients that are fairly stable and don't really require an acute bed like I was talking about earlier, and potentially could be sort of discharged on the same day of sort of coming in, or same day of review, really. They can be sort of discharged from hospital and they don't need to be admitted. So these patients usually should be fairly mobile. So I mean, we do take patients that come in, for example, on a wheelchair, but if they are sort of unwell, usually we'll just get them to come through the emergency department and usually get them admitted that way. So the ambulatory care unit is usually those reserved for those who are sort of fairly okay, fairly mobile, and are able to sort of come in. And they, for example, they don't need an oxygen requirement or anything like that. And they need to be COVID negative, especially with what COVID going on now. We sort of want to make sure that's still a sterile area, really. And then again, I'm going to be talking about sort of from the medical point of view, because that's what I do on a day-to-day basis. So the patients that get referred to us, to the medics, and if they feel, if I feel that they require an admission, then usually our site managers or bed managers will sort of need to sort out a bed for them. And either they go to the acute medical unit directly, which is sort of the first sort of transfer, I guess, that you can talk about from the emergency department to the acute medical unit. And this is where our acute physicians, our consultants, will review these patients and sort of decide whether or not, yes, they can get discharged, hopefully within 24, 48 hours. Any further investigations that they require, any further bloods or investigations or imaging, or any further discussions with any of the other sort of specialties that maybe require the input, basically. Yeah. Or they can be directly sort of referred to a specialty ward. So when we talk about a specialty ward, quite a good example of this now is sort of the COVID patients that come in. So patients come in with the typical symptoms, shortness of breath, cough, runny nose, loss of sense of taste and smell. And the key thing is they have an oxygen requirement. So usually these patients need to be on a proper respiratory ward. So what happens is they don't go to the acute medical unit, they go directly to our respiratory ward, which again, some hospitals, depending on the number of cases, they have a designated ward specifically just for sort of COVID positive patients or patients with symptoms of COVID that require that have oxygen requirement, just to minimize the risk of sort of transmission and things. So they either go to a dedicated respiratory ward, or they come into even a general internal medicine ward, but dedicated just for sort of COVID. So again, depending on the number, sometimes they might just dedicate this a bay for those patients, really. But it just depends on how many of these patients are really coming in. And unfortunately now, during sort of winters coming up with flu and everything, we probably will be seeing a bit of an uptick of these patients. So there's something to be sort of wary about, really. But yes, generally the patients will be transferred either to a general internal medical ward, which is usually under 75, or an elderly care ward, which is over 75. That's basically how we do it in our hospital at Isari Hospital. So the key points that I just want to emphasize in terms of transfer of patients is, again, very, very important, the appropriate sort of specialty referrals. So again, it's just the key reason why I want to emphasize this is just to make sure that these patients are managed by the appropriate specialty teams, and in terms of they being in sort of the right places, because it's not just about, I guess, the consultants and the junior doctors that's taking care of them, but you need the sort of proper nurses. So like, for example, urology nurses will sort of have more knowledge on urology compared to sort of medical nurses or surgical nurses. So that's what I'm trying to emphasize, they being in the sort of specified place so that they get the optimal care possible. That's the sort of key thing. And the other thing I just like to emphasize is the appropriate transfer of patients to sort of the designated specialty wards in the acute setting. So again, very similarly, I just talked a bit earlier about how this patient that come in through ED should go to sort of, for example, the respiratory ward if they come in with sort of respiratory symptoms or COVID symptoms. But even sometimes, because I just remember I had a case like a couple of weeks ago where a patient can just become acutely unwell on a general medical ward, on elderly care ward. He sort of started desaturating suddenly. He's a known COPD patient. And this is where I guess your critical care team gets involved. So you put out sort of an emergency call, they come and review them. This patient particularly, I mean, we did a blood gas on him and he had sort of quite bad type 2 respiratory failure. So it looked like he sort of decompensated sort of type 2 respiratory failure on the background of his COPD. But he came in with, I think a bit of chest pain, and I think it got ruled out as a musculoskeletal related pain. But you see, you get sort of redirected with other issues when the patient are in hospital and you have to deal with it. But that is the importance of what I talked about earlier, the sort of multidisciplinary team approach, where you get the critical care team to get involved. They are normally quite good in dealing with this non-invasive ventilation. And they usually coordinate with the bed managers and they try to get them, for example, back to the respiratory ward where they should be and managed by a proper respiratory consultant. So in that sense, it's important when these acute issues arise, you have these different people that can work with you. And again, at the end of the day, it's about making sure that the patient is safe, making sure that the patient is patient's care is sort of optimized. So that's a key thing sort of involved, really. So coming to referral. So in terms of the day-to-day sort of jobs of a junior doctor, this is something, if you are working for the NHS or you're new to the NHS, it'll be sort of your day-to-day job in terms of what you need to do, because more so in the hospital setting, inpatients, a lot of times the acute physicians, which is basically what I am, sort of acute physician slash GIM medicine. But a lot of times, like the case that Dr. Prabhisha showed earlier, where you need gastro input, for example, or you need a dermatology input, for example, for a patient comes in with abnormal skin lesion. So we are not that inept or that adapted to sort of give our expert input. So that's the reason why we get different teams involved. And that's what basically they're there for. The dermatology team, for example, in our hospital doesn't have an inpatient ward. So we can't like transfer a patient that comes in with an abnormal skin lesion to a dermatology ward. We don't have that. But we get their sort of input. So they come and review the patient. They give us their sort of expert advice on how to manage this patient, if we need to do any blood tests, if, for example, they need a skin biopsy. So they are usually good in sort of managing that and giving us their expert advice and input on how to best move forward with these patients. But this is something that as a junior doctor, when you, I guess, join the NHS, is sort of part of your day-to-day job. You'll be making a lot of calls sometimes. Some hospitals, the previous trust that I worked in, it's an online referral, which is fairly quite good as well, because it's all documented and it's I find it's a fairly sort of easier system rather than talking to somebody over the phone, because sometimes depending if they are offside, for example, it's out of hours, just make things a bit more difficult. But it will vary between the trust. Sometimes it's sort of like a written referral, so you just pop into the office and hopefully one of the specialist trainees or even the consultants sometimes review those referrals directly and they come and sort of review those patients. So different mechanisms involved, but again, at the end of the day, is like I said earlier, it's just trying to make sure that the patient is getting the appropriate input from the appropriate specialties to optimize their care, really. And again, just emphasizing what basically that they're going to be doing is the advice basically on what investigations is going to be required, how we're going to manage this patient moving forward, and if there's any, I guess, any other secondary issues sort of involved other than the primary issues that they might have come in with. So that's very important. The other thing that you might be calling them about is like what I mentioned a bit about earlier, is about referrals to take over the primary care of the patient. So, for example, a patient comes in with maybe, I guess, sort of piggybacking on what Dr. Prabhisha's case was earlier. So the patient comes in with, for example, diarrhea and vomiting, a bit of abdo pain, had referred to the medics because it looked like a simple case of gastroenteritis, but maybe they had a CT scan after which showed, for example, a perforation or an abnormal fistula. So we think that the issues that she's come in with is more related to her surgical concerns rather than a medical concern. So at that point, it would be, they've probably already been referred to the medics. So the primary sort of care physician is the medics, but at this point, it's probably best that we transfer the care to the surgeon so that they can optimize her care in terms of whether or not they're going to move forward with surgery, for example, if they're going to sort of fix the perforation, or they're going to sort of fix the fistula. So it's probably best dealt with the surgeons rather than medics. So this is the key thing in terms of referrals as well. When you sort of talk to the person at the other end of the line, or when you're writing the referral, what exactly is that you want them to do? So is it just more advice? Is it more that you want them to sort of take over the care of the patient? So that's the key thing involved there. In terms of referrals to sort of tertiary centers for advice and transfer of care. So for example, East Surrey Hospital, it's more of a district general hospital. So we don't have, for example, a neurosurgical service. We don't have a renal service, for example. So patient comes in with sort of a bleed in the brain. So it comes in with sort of maybe, for example, weakness or expressive dysphasia, had a CT head done. as part of a stroke call when they come in, and it's found that they have like a massive bleed in the brain. So this is where we won't be able to manage this locally. So this is something that we need to get advice from sort of a specialist center, which our closest neurosurgical center is St. George's Hospital. So in that regard, it's an online referral. So they're normally fairly good in sort of responding fairly quickly. But the key thing is we need to make sure we transfer the images across so that their specialists can review it, and then they can give us advice on whether or not they want us to transfer the patient there for potential burr hole and sort of burning out of the blood, or maybe the patient is too frail, for example, and they're just going to be for conservative management, then they can't really sort of do anything much. But that's the reason why we have sort of these tertiary centers available, because not all NHS hospitals has all the specialties in one place. They have sort of these tertiary centers, for example, like St. George's has a neurosurgical center. We have the liver unit at King's Hospital or Guy's and St. Thomas's Hospital. So, for example, a patient comes in with a paracetamol overdose and they have quite deranged liver functions. Their blood gas show they're quite acidotic, the pH of less than 0.3. So they sort of meet that criteria for a potential liver transplant. But before we, I guess, jump to that, we need to speak to the liver specialist at sort of King's Hospital or Guy's and St. Thomas's to get their input. And then they, again, will give us their advice. And most likely, if it's like a young lady with sort of psychiatry issues and normally fit in well, these are the ones they normally would sort of pick up quite quickly and get transferred quite quickly for potential sort of transplant and things. So that's an important key thing to be aware about. Then we come to sort of this MDT referral. So this multidisciplinary team meetings are fairly common in the NHS. The most common one that we usually see on sort of a day-to-day basis, like on the wards, is this sort of cancer pathway MDTs. So we have something called this 2-week wait referral. In most cases, it's actually done by the GP directly. So for example, an elderly gentleman comes in with red flag symptoms. So anemia, they come in with sort of weight loss, night sweats, for example, and their main complaint is they're having difficulty swallowing, for example. So the first key thing that you need to rule out is malignancy. And if they have this sort of what we call red flag signs, the GP sort of can directly refer them to what's called this 2-week wait sort of pathway. And basically they get seen in sort of clinic within 2 weeks. And hopefully they'll get sort of the imaging done. They might need to get like for this gentleman that I'm talking about, they might need to get an OGD done to have a look and see if there's any sort of esophageal or gastric malignancies. And then if that is confirmed, then of course, the cancer doctors, the radiologists that sort of done the scans for sort of staging. So if something is confirmed on the OGD, they'll get the basic CT scan of the chest, abdomen, and pelvis to sort of more so stage the cancer if to see basically there's any spread. And then they have sort of this big meeting with sort of the upper GI surgeons, the histopathologists once they take the biopsy. After the OGD, the radiologist will be there reviewing the scans, and the sort of oncologist is there sort of to advise on what, I guess, based on everything on the scans and the histopathology, the oncologist will advise on what sort of treatment in terms of chemotherapy or radiotherapy that they might be able to sort of offer the patient. Again, of course, depending on their performance status and how aggressive the cancer is and things like that. So all this is sort of discussed and taken into account during this MDT sort of discussions that they have. And I guess that the key thing is it's not just limited to sort of cancer pathways. So a lot of times that we don't routinely see is, for example, in different specialties. So like, for example, cardiology or respiratory medicine. So for example, in cardiology, so they have, if you have a patient that is quite complex, it's usually discussed in an MDT. And usually those MDTs are just usually the cardiology consultants. Let me try and see if I give you an example. So for example, a patient with a really bad calcific sort of aortic valve, and he potentially needs sort of an aortic valve replacement. But for whatever reason, he might be sort of a complex case. He's had imaging or a cardiac MRI, which shows either sort of it's quite a difficult replacement that to be done, or he might be sort of a high-risk patient depending on his comorbidities and things like that. So all that needs to be taken into account. So it's not sort of just that one lead cardiologist that's seen the patient to make that decision. So if it's a fairly complex case, all the cardiologists within the department usually can get together once or twice a week. And sometimes they even can even do something like a video call with the cardiothoracic surgeons, for example, in the tertiary centers, and they can discuss the case as well. And then decide whether or not he would be an appropriate sort of candidate for a proper aortic valve replacement, or if they just need to do like a valvuloplasty, for example, if he's sort of too high risk. So there's sort of certain things that gets discussed in this multidisciplinary team sort of meetings, because the main idea behind this, again, I'm not sure whether it's done in sort of other places, but within the NHS, the key reasons why they have this sort of MDTs is they talk about shared responsibility. So it's not just one person making that decision for especially this complex sort of patients. Some people may call it sort of defensive medicine, but it's more, I think, about shared sort of responsibility and sort of more accountability, because when you have different colleagues of the same specialty, or consultants or physicians that are discussing the case, and you come to an agreement, it sort of it bears more water, really, in terms of how we manage the patient and making sure that the patient is safe, really. So again, just the key points here is knowing why you're referring the patients. A lot of the times as junior doctors, when you sort of go on around, or when you sort of review patients with your consultant or with your registrar, they say, okay, you refer to the gastro doctors or refer to the urologist. But knowing why you're sort of making that referral, because sometimes being quite junior, because I remember when I was sort of doing foundation, when I was F1, just starting out, you're getting used to the systems, you're getting used to how to review patients, you are sort of trying to improve on your clinical skills, and you're just fresh out of med school and things like that. So it's very important sort of knowing why you're making this sort of referral. So is it just for advice? Is it just, is it that you want them to take over the sort of care? And the key things is, and again, this comes with experience. I mean, no one expects you to know it sort of from the get-go, but it comes with experience when you make lots and lots of referrals. But the person at the other end of the line that you're talking to, it would be a consultant. It would be a sort of a trainee. So it's basically what information that you want to get out of them to best improve the patient care, really. And at the end of it, what is the desired outcome? So basically, do you want the specialty team to come and actually review the patient, or do you just want some advice over the phone on how to manage the patient, and then maybe you can give a call back after a day or two to see whether that management has worked, and then if it's not, then sort of re-refer again to sort of see how best to manage that patient. And then again, it's just sort of referral to the relevant specialties. Again, this is a key thing about the referrals, going back to when we talk about how they come in through ED as well. So this is an important thing. Yeah. Good. So coming to discharges. So once we have managed the patients, and we feel that the sort of key thing that we always talk about, and again, if you work for the NHS or you come for work for the NHS, you'll realize that once you have, I guess, treated the patient, they come in with, for example, a chest infection, you're giving them IV antibiotics, they're feeling much better, the inflammatory markers are improving, you switch them to oral antibiotics, then we say they are medically fit for discharge. So that's what MFFD means. So medically fit for discharge, or some hospitals say medically optimized for discharge. So this is sort of the keyword that is sort of we document in the notes to say that the patient is well enough to be discharged from hospital. And this is where I guess we start our what we call discharge planning. So like what I mentioned at the start of my talk is facilitating safe discharges to wherever the patient needs to go. So at the end of, I guess, their stint in hospital per se, you want to make sure that they safely go back, they get safely discharged from hospital. So when they go out of hospital, you want to make sure that they're safe. Of course, in certain cases where, for example, if the patient has capacity, and they want to self-discharge, for example. So what we mean by self-discharge is sort of discharging against medical advice. We can't stop them because they have, for example, if they have the capacity, if you feel they have the capacity, they can get discharged. But that would be an example of an unsafe discharge because, for example, if they come in with, I don't know, melena, for example. If it's a young chap, alcoholic, comes in with sort of melena, you think it might be an upper GI bleed or variceal bleed, but he has capacity. He says like he doesn't want to be in hospital. He understands the risks involved, that he might have a massive bleed, he might collapse, and I mean he might even die from massive blood loss. As long as he understands the information, he's able to retain it, he's able to, I guess, weigh up the risk and the benefit of it, and able to inform you of that decision that he wants to self-discharge. That means he has capacity, and we can't sort of involuntarily keep him in hospital. But these are, I guess, this is an example of an unsafe discharge where potentially he may collapse and come back to hospital even more unwell than when he sort of came in earlier. So these are sort of things that you might come across as well when you see patients, for example, on the ward or during an on-call and things like that. So example of course, a discharge destination. So if the patient is well enough, they can be discharged home. So if there's no concerns about sort of their mobility, for example, if there's no concerns about how they're doing at home, then they get discharged directly home because they might have like a support system at home and things like that. So family, friends, or family members that are able to help out, then you think that we can safely discharge them home without any further input. But some patients who, like in Dr. Prabhisha's case earlier, who are quite frail, elderly, who come into hospital, they might need a bit of sort of SIM rehab to help optimize their mobility a bit more before they get, I guess, discharged to whether back to a nursing home or care home or whatnot. So that rehab stint is just like a short period to help optimize their mobility and make sure they're, again, hopefully as safe as possible at home. Then they have something called Respite Care, which is sort of like an interim sort of care bed. So they might have some rehab in this Respite Care, but it's more so about they don't really need an acute bed or an acute hospital bed. They are well enough such that, for example, like the case I was talking about earlier, they're on already oral antibiotics for the chest infection. They don't need any more repeat bloods doing. They don't need any repeat imaging doing. But they're just sort of not that well enough to go back to their home. So it's just like an interim bed, just whilst, for example, if they need their package of care to be put in place, or they need some sort of placement to be put in place. So that's sort of the idea behind sort of a respite care. And then, so package of care, POC, sort of patients with, who need maybe a bit of help at home, because like I said, they're just a bit more frail, they're a bit more sort of vulnerable. Again, this is more so sort of elderly patients. So they just need a bit of help with, for example, making their meals, just maybe somebody just to check up on them, maybe twice a day or 3 times a day. Again, the more sort of frail or the more vulnerable ones will need a larger package of care. And of course, if that's not sufficient, then we talk about sort of placements for them. So whether it be a residential home or a nursing home for these people. And then hospice is a term coined for patients that we feel are terminal. So basically approaching sort of end of their life, really. So patients with metastatic cancer, not amenable to any more sort of chemotherapy or radiotherapy, and they're sort of more so for palliative care. So hospice are sort of the discharge destinations for these patients. So again, we talked about earlier this sort of multidisciplinary team approach for these kind of patients. So the people that do get involved, of course, the patient themselves, because they want an idea where they want to be, they need to sort of express that sort of decision. Family members, family friends sometimes can help out, but in terms of the people in hospital is our physiotherapists, our occupational therapists. So our physiotherapists, again, more so helps with the how to optimize the patient's mobility once they are medically fit for discharge. Our occupational therapist, for example, helps out in trying to put equipment at home if they need sort of like a stand, or if they need sort of a transfer bed, or if they need a hospital bed, for example, a patient, for example, who have really bad pressure sores and they need like a proper sort of mattress cushion, a proper hospital bed. to minimize the risk of the sort of sacral source becoming infected or becoming sort of osteomyelitis. So this is where our occupational therapist gets involved and helps facilitate the sort of hospital beds to be put in the households and be fitted in the households and things like that. Social services are involved in terms of trying to get this package of care, of the patient needs a placement. So they sort of deal with the funding involved in this, and once they get the funding, whatever sort of agencies or services involved in the package of care, they normally liaise and coordinate a lot of these things. The fast track team, which is basically what we call our end of life care team, they coordinate in terms of the patients that are approaching end of their life or terminal patients. They normally liaise with our palliative care teams, and they sort of coordinate if the patient, for example, wants to die at home, so they try and coordinate that in terms of the funding and trying to get things in place. Or if the patient wants to die in the hospice, then they can try and coordinate that as well. Then we come to about sort of complicated discharges. So again, this is something that you'll sort of face a lot of the times. And the issue that what we always have in terms of patient flow is a lot of the time is because of these complicated discharges, where we say the patient is mentally fit for discharge, but we can't really place them anywhere, or we're finding it difficult to place them. And a lot of the times the reasons for this is it might be because of safeguarding. So when we talk about safeguarding, it basically means if there's any concerns with, for example, their current package of care at home, if there's any signs of neglect or abuse, this is something that we need to get on top of before we can, again, safely discharge the patient. And then, of course, we talk about patients with complex sort of needs. So again, it's a lot of the times, a package of care won't be sufficient, or the patient needs like a proper sort of placement, or whether it be a residential home or nursing home. Usually it's not sort of clear cut in terms of their needs. So for example, we had a patient just on our ward that stayed with us on the ward, an inpatient, for almost 3 months. It's just because once he was mentally fit, it's just sort of he had a lot of care needs because he was, I think, a patient with previous traumatic brain injury. I think he had a sort of catheter in situ. So there was a lot of issues in terms of getting a proper placement for him, because there was a lot of disagreements in terms with the next of kin and sort of social services about where the best place that he can be. For example, I think they had like a placement for him a bit of a distance away, but the family was not happy with that because it's too far, they can't visit. So it sort of complicates things a lot of the times. And it's about sort of training personnel to sort of care for this patient. That was also sort of an issue involved. So he was actually with us for about 3 months on an acute inpatient bed, which, I mean, completely doesn't make sense, because when you think about sort of the GIM beds or this acute hospital beds, it's for acute patients. So they shouldn't really be staying that long. Either they should go somewhere like an interim bed, or they should get sort of discharged from hospital as soon as. But because of these complex needs that they have, it just complicates things. And basically they just stay there because we know the patient well, and it'll just be day to day, oh, patient's mentally fit, and like, where are we with the social sort of standpoint? So a lot of times our hands are tied, and it's a bit harsh to say, but I mean, these patients unfortunately are sort of like bed blockers, because we get a lot of new admissions and we can't place them. But a lot of these patients are mentally fit and are just sort of unfortunately just waiting around for a care package or some sort of placement. So it just makes things a bit more difficult in terms of how we sort of get that patient flow through hospital a bit more efficient and a bit more better, really. And then we talk about sort of follow-up for patients. So patients that are medically fit for discharge, and we discharge them. Some of them might need a follow-up review. So pre-COVID days, we used to do a lot of our face-to-face follow-up, and we actually used to do it in our ambulatory care unit at Isari Hospital. So basically, an example would be maybe a patient with cellulitis, had course of IV antibiotics, now switched to oral antibiotics. Usually the diabetics maybe need a bit of a longer course of antibiotics, for example, or patients with peripheral vascular disease might need a longer course of antibiotics. So what we tend to do is we book them in for a face-to-face follow-up in 2 to 4 weeks time, once they sort of completed their course of antibiotics or extended antibiotics courses. And sort of we see them in sort of these clinics, these ambulatory care clinics or specialist clinics really. And we sort of review them. If things are getting better, then yeah, well and good. We discharge them completely. If things are really not improving, then we might again maybe get a bit of input from our dermatology colleagues or vascular colleagues to find out, oh, why is this sort of cellulitis not improving? And then if it's the case that the antibiotics is not really that effective, then again we will get in contact with our microbiology colleagues to get their input and expert advice on maybe what sort of escalation of antibiotics that the patient might need to make things better. And then maybe you might see them again in a couple of weeks, for example, to see whether or not things are improved. So that is sort of the concept that I talked about earlier about sort of this shared responsibility, where we get input from the different specialties to try and make sure that we are optimizing the care that we're providing for patients. Since COVID, unfortunately, we've been doing a lot of telephone follow-ups. And I think it's a lot of what I guess the GPs are doing nowadays as well. So they sometimes do like this video calls for patients who are a bit more tech savvy, or just a routine telephone follow-up just to find out how you're doing after the fact. So unfortunately, well, fortunately or unfortunately, I guess, a lot of the times we're doing sort of this telephone follow-ups, which again, in one way, it sort of saves a bit of time for both yourself and the patient because they don't have to come in. But at the same time, it sort of, in a way, sometimes neglects that clinical sort of input or your sort of your examination skills to actually have a look and see, because sometimes things are not as clear, for example, on sort of the sort of video call that you have. So it just makes things a bit more difficult, really. And then, of course, referrals for further investigations as an outpatient any sort of further investigations as an outpatient that can be done. And this gets referred directly to the specialty. So if gastro needs to see them directly, then we can refer to the gastro team. And then we might just need to speak to their secretaries, the gastro consult secretaries, and ask them to just make a follow-up appointment for them and get seen, for example. And most times than not, and sometimes our GP colleagues do get annoyed with us about this, but what we basically say is refer back to the GP for follow-up review. Again, I mean, a lot of this are guilty, I guess, of doing this. Sometimes it is appropriate, sometimes it is not. But I think the key thing is when we do that, so when we do our sort of discharge summary, when the patient gets discharged from hospital with their medications and a summary of their admission, the key thing is what we tell the GP. So for example, if you want the GP to repeat some blood test results in a couple of weeks, or if you want the GP to follow up an investigation, for example. So it's actually inappropriate to ask the GP to follow up an investigation that you have requested, because technically the onus is on you because you have requested it. You should be following up. And that's why we have our follow-up clinics in the ambulatory care unit, for example. But for example, if it's just a routine blood test for patients with, a deranged liver function test, for example, coming with cholecystitis, has deranged liver function, they don't really need to come back to hospital, for a follow-up review, because the GP is probably closer. So you can ask them to repeat the liver function test in a couple of weeks, and the GP can just review it. And if things are improving, then well and good, we don't have to follow up anymore. The key issue, unfortunately, is this, in this regard is, unfortunately, in this day and age, in this climate, our GPs are fairly inundated with a lot of patients and referrals, and they're quite busy with admin work and things like that. So a lot of the times they actually only come across the discharge summary from that particular patient in about a month or in 6 weeks time. So that's something to sort of bear in mind when you are making or writing the discharge summary as a junior doctor to the GP, is bearing this in mind. That GP is probably only going to see that discharge summary in about 4 to 6 weeks time. So that's something to bear in mind if you're asking them to follow up something, or if you're asking them to repeat some bloods, for example, is that they might not actually get to it at that point. And that sort of, again, will delay the investigation that you're planned for the patient. So more often than not, you probably just ask them to come back into our ambulatory care unit, because you control the sort of the list of patients that come in. So you can fit them in wherever it needs to be. You can do whatever repeat blood tests required, and then you can just follow up from there, really. And then, of course, we have our district nurses that is sort of either associated with the hospital or associated with the GP. And again, they're fairly good in managing, for example, patient dressing. So patient comes in with really bad sort of cellulitis with blisters or superficial ulcers or diabetic foot ulcers, for example, which needs regular dressing. So our district nurses are very good in managing that to minimize the risk of infection and things like that. We also have, for example, our outpatient antibiotic team. So again, very similar case. So a patient with osteomyelitis or proper diabetic foot ulcers who need extended IV antibiotics. And you feel that they don't actually, they're sort of well enough to be in the community and they're not sort of really requiring an acute hospital bed. These patients can actually go back home, and we get sort of our district nurses to administer actually the antibiotics if required. Another example is patients with a clot in the leg who need injections, the sort of blood thinning injections. If they can't do it themselves or a family member can't do it for them, then we have district nurses that can help come to the house on a daily basis or sort of every other day, for example, to sort of do the injection. So that's the functions of our district nurses. And again, they're very, very good. And we usually utilize their expertise because they're able to do the observations. They can check diabetic patients' blood sugars. Some of them can even take blood. So it really helps out our day-to-day sort of work in terms of minimizing and sort of sharing the workload, really. So just lastly, talking about the discharge destinations in a bit more detail. So again, like we talked about earlier, patients going home. So we have our sort of PTOT who assesses the patients when they are mentally fit for discharge. And if they feel they don't need any further input, then they can sort of go back home. In terms of rehab, we have like sort of rehab hospitals. We have sort of this community rehab centers. It's sort of like a dedicated hospital just for rehabilitation with dedicated physiotherapists, occupational therapists. They might maybe have a doctor there, but just for routine stuff, if need be. And this is where sort of the ongoing physio sort of really takes place. I talked a bit about Respite Care, which is sort of the interim placements that we have. We talk about this packages of care. So again, it can be sort of self-funded or sort of family helps out with the funding for this package of care. Social services do get involved because, I mean, again, in terms of how things work in the UK and how our National Health Service works in the UK. I mean, we are sort of what we call a welfare state. So where basically the NHS is funded by sort of taxpayers, really. But a lot of the time we don't actually realize not everyone who gets admitted to hospital, whether or not they pay tax or they're retired or they're working for the government or whatever it is, anyone who gets admitted to hospital, not everyone necessarily qualify for sort of funding. So a lot of the times is we talk about, and I'm going to talk a bit about this sort of placement, again, very similar to package of care in terms of residential homes and nursing homes. So a lot of the times, the people that provide the service for the packages of care, the people that run residential homes, the people that run nursing homes, are sort of part of the NHS, but it's sometimes through sort of private or private agencies, really, or private companies that actually run this. So sometimes social services are just, like I said, the patient is not qualified, depending on their, for example, their income or depending on their sort of social circumstances or sort of funding. If they don't qualify for it, then they have to sort of pay out of pocket. And there's some sort of, which I even found out when I first couple of years of me working here, is that actually if you own a house, for example, and you're elderly and you're in need of sort of a residential home or a nursing home, the council, which is sort of like the local council, actually takes over your home and they provide sort of the funding in exchange for taking over your home. So in a way, technically you're actually losing your home, or you're in a way trading off your home to be placed in a nursing home rather, and that will sort of be funded by the council directly because they've sort of taken over your home. And then, of course, the hospice, we talk about this end-of-life care team or fast-track team. And again, very important for these patients, for example, who are approaching end of life with, for example, a patient with ovarian cancer who develops sort of massive amount of ascites, sort of swelling in the tummy. So the hospices are normally very good in managing their sort of pain or agitation, if they have any secretions, and things like that. And they themselves actually can do a lot of the procedures. For example, the acidic drains or chest drains, for example, they actually have trained personnel in the hospices directly to help with that, because a lot of time these patients, like I said earlier, approaching end of life, their terminal phase of their illness, they don't want to be sort of being sort of carted back to hospital and going through the whole rigmarole of being admitted and things like that. So the hospice care is a dedicated place for these kind of patients, and they can get sort of the symptomatic management fairly quickly as well. Yeah, that's it for my talk, really. So if you have any questions, I guess you can put it in the comment box.
Amazing. Thank you so much, Dr. Kulang. That was really amazing. Honestly, I personally feel like this is the second half of the job that no one talks about. And if you can really sort of get your head around it, it helps you so much moving into the future. But just quickly, before we do go into the questions, I just want to, just going to try and get my screen up here. Okay, lovely, lovely. So before we move on, first of all, I just want to thank our sponsors, Lectorio. They've been great, and it's an all-in-one study resource for medical students that combine learning science and medical education into one easy-to-use platform. For all of you who will fill the feedback form, in which I'm going to post right now as we speak in the Q&A, you should be able to see it under answered questions. Just click on it. Or if you want to make your life easier, just point your phone camera at QR code and you should be able to be honest with us. Right, I'm going to move very, very quickly into the questions. And I've got actually quite a few interesting ones. So I think one of the ones that popped up most commonly was how much variation between the whole process and the paperwork do you get between trusts and deaneries? I know myself it's a little different in Scotland, but I'm not too sure if that's just NHS Scotland and NHS England, or if that's just between trusts altogether. I'll let any of you guys.
Oh yeah, I was going to say, I mean, yeah, I'm happy to answer that. Sorry, the question was in terms of the paperwork you said.
Yeah, I think in general, like in regards to the whole process, really, if there's any variation at all between trusts, because I know sometimes the paperwork can be different. But is it usually along the same lines, or can it be quite different?
I think it's fairly similar. I mean, I've now worked in Scotland, so I mean, my jobs have always been in sort of NHS England, so I won't be able to comment on the ones up in Scotland or Ireland, for example. But in England, there might be some variation in terms of, like, for example, Dr. Pravisha had the clerking booklet that we have for all the patients that get admitted under medicine, for example. So that's the sort of standard booklet that we use at East Surrey Hospital. There might be some variations in terms of what, I guess, boxes might be in there. So I guess when, for example, when COVID hit, we actually introduced a box about vaccinated patients, unvaccinated, when was the last dose and things like that. So that's sort of a fairly new box. But the general one would definitely be sort of the presenting complaint, history of presenting complaint, I guess how, and any obvious past medical history, medications that the patient are currently on, examination bits, your differentials, investigations, and sort of management. So that's, I think, fairly about the same, my guess, in sort of most trusts. I don't know whether Pravisha has any other sort of experience in that regard.
My view is every trust is really different. Like, it's a little bit contradicting, only because where I worked before, it was they had like different systems for stuff, and it was like very much paper notes based, whereas in East Surrey, you know, every ward is different, but we're mostly on this one system where everything's on it, all the bloods, all the x-rays are all in one system, and we do our notes on it. So it just takes a little bit of transition time from trust to trust to learn, but most of the general things are the same. I mean, in my previous trust, referrals were done by paper and forms, whereas here we write letters to specialities, which is really quite unusual compared to the last.
I've heard that before, and I was just like, oh my God. So, you know, it was a total shock to me. Actually, another question a Scottish friend of mine's asked me was, is the acute medical unit the same as the acute receiving unit in Scotland? And the answer to that is yes. We just call it something entirely different. So we have the ARU instead of the AMU. So I think you get these small little variations for sure. Okay, so I think the other question I think this one's for Dr. Coogan. If patients who are fit for discharge but are waiting on acute ward beds, can they not be put into less busy wards like medical or surgical wards while they're waiting for that discharge?
So you could do. So basically, yeah, I mean, if you feel that the patient is medically fit for discharge, I mean, you think, yeah, it'd be easy to just sort of move them to sort of another ward where it's sort of like, yeah, doesn't really require much medical input. Maybe they just need a bit of physio, OT, and then they get discharged from there. We actually used to have that at East Surrey Hospital. So we had what's called an integrated rehab unit, called an IRU we had here, where basically it is exactly what it is. So when the patients are medically fit, maybe they're just waiting for a package of care or some sort of placement, they go to this unit and they get transferred there directly. Unfortunately, the issue that we have now is just because of how busy the hospitals are, our IRU is now actually a proper ward already. And in the last 2 years, I mean, Prabisha might not know this, but in the last sort of 2 years, because I was in the hospital 2 years ago, we've sort of built 2 new wards just for medicine, just because of the amount of admissions that we're getting, and we're just sort of not really able to cope. Even now, I mean, we're using sort of our recovery unit in endoscopy, for example, and we're using sort of our angio suite just to put patients, because we just don't have enough beds. And unfortunately, again, it comes back to that problem that I mentioned earlier, is because we have a bit harsher way of saying it, but these sort of bed blockers, and they have all sorts of complex issues. They are sort of complex discharges. They stay there for ages and ages and ages. And we just can't get the new patients coming in, and we just can't place them anywhere because a lot of these patients are just stuck there, which is, yeah, unfortunately the issue.
Yeah, I don't think it's a win-win situation for anyone, because obviously it puts the strain on the NHS. And if you talk to the patients, they don't really particularly want to be there either. They want to get discharged. So it's painful like both ways. But I think really it just comes down to that sort of situation where it is what it is. And we just got to work around it. Absolutely. Dr. Prab, actually, this next question's for you. So somebody's asking, what route did you take after graduation?
Okay, so I know that many of you are aware of like the different possibilities. I think I did a shadowing period for 2 weeks. It was really hard for me to get clinical attachment. Some of the rules have changed. You need to have Nhs Number, you need to know a consultant, you need to be referred to get a clinical attachment. So I started doing shadowing for 2 weeks. They then offered me a job as an F2 bank, which I wasn't too happy about. Being a bank is good because you're still part of a trust, so you still have that support. I didn't want to locum. I know how locums work. They get moved around everywhere, and I just wasn't confident about using systems. So I just started applying for jobs through NHS jobs, and I got a few interviews, and I just picked the best one, I guess. And I ended up at Surrey because of the CQC, because it's outstanding and it's meant to be the best of the best. So I'm here.
Representing, huh? Nice.
Yeah,
Okay.
it was good.
Right. Next one's quite tricky, so I'm guessing this one's for both of you. I'll let Dr. Coogan have a go first. What happens if the patient is not comfortable sharing details?
Oh, I mean, I guess, again, it depends, because in terms of the patient that I guess we do see in hospital, I mean, a lot of the patients that we get, and again, it's probably mostly going to be those with sort of psychiatry issues, sort of patients with for example, paracetamol overdoses or deliberate self-harm. A lot of these patients, probably will not want to sort of share information. They don't really want to talk very much. They just want to go home, for example. But again, this is sort of, I guess, a complex admissions where we, of course, we get our sort of liaison psychiatry colleagues involved, and we sort of, I think we treat the acute medical issues first. And again, I think sometimes it goes back to whether they want to be treated or not. But again, it goes back to assessing their capacity. So if they don't want to, I guess, tell us why they're there, then it'll seem a bit weird, because how they come into hospital. So I think it's about exploring sort of the circumstances of why they're in hospital. So if, for example, it might be a worried family member that's bringing them in. If they're not, for example, eating and drinking, they're sort of self-neglecting at home or whatever. Or the other example is like, a young teenage girl that the parents have brought in because she's come in with a paracetamol overdose or tried to sort of end her life. So this is where, I guess, it makes things a bit more tricky, because again, we don't want to treat patients against their will, but at the same time, you want to provide the best possible care. And this is where, I guess, it gets a bit more sort of muddy in the waters, in the sense we do need to get our liaison psychiatry colleagues involved. Sometimes, in some cases, we need to get our medical legal department involved as well, is because, for example, a patient who refuses treatment, and they do seem to have capacity. So like, the patients that come in wanting to end their life or with a paracetamol overdose, when you talk to them, they actually have capacity, but they just say like, no, I want to end my life. I don't want to be here anymore. So it's assessing their capacity, and we have sort of this Mental Health Act or Mental Capacity Act. It's a bit tricky sometimes. So that's why we get the different specialties involved and get their input, and hopefully best manage the patient like that. Yeah.
Absolutely, I couldn't agree more. Dr. Prab, would you like to add anything onto that? I think that was pretty.
Yeah, I'll just explain like what my approach is like to really difficult patients. I actually enjoy really difficult patients. Actually, if there was a specialty for difficult patients, I would go for it. Sometimes it's a little bit daunting doing ward round and just having loads of the team like come in and barge in and ask like really personal questions, and they're just sometimes not really up for it, and they're kind of shy and shadow away. I just tend to go see the patient maybe after lunchtime and just go sit with them and talk with them and just ask like how the day is, what they eat, and like go normal, and then try to creep into those more personal questions and make it a little bit more easier for them to open up and make them feel like you're not, questioning them like this, and more of a conversation and building that, rapport against you both, and just that trust. And then they tend to open up after a while. Then they don't stop. Then the whole life, which is good.
Absolutely. Okay, so we're just gonna do a couple of the quick ones. So I think this one again is for Dr. Prab. Do you think doing an ALS course is necessary to get your first trust grade job?
No, I still haven't done my ALS. It's booked for February, but I think ALS is really important if you're going to be working on A&E. I know I'm on call. I've done my BLS and my ILS. There's just a waiting list for ALS, but it's good. It stands out if you're applying for jobs, for sure. Like, it's something that bounces right at you, but I didn't have it, and there's other things that you can have that really bounce out just as good. It's great knowledge. Even if you don't do the exam, if you read the content, so you're prepared for it. Yeah, I wouldn't say it's a necessity.
I think absolutely, I couldn't agree more. I think it's definitely not necessary. Personally, I'm going to do mines early next year because like Dr. Coogan here, I'm just one of those acute med junkies. And I just love those kind of situations. So I really want to get into the AMU and A&E. But I think one thing I will tell a lot of people is I have a lot of friends studying with me, even though they're not planning on doing their ALS anytime soon. And I think it just comes back to what Dr. Prab was saying. It's something that's really good to know. Whether you do the ALS or not is something you should definitely know walking into the hospital at all. So I'd recommend everyone to definitely read up on it. Absolutely.
And you have to do that ALS like every year. So I wouldn't really advise anyone in like uni to do it until
I think it's 4 years.
Oh, is it every?
Every 4 years
now. So they've been about it for 4 years now. So,
okay.
Yeah, so you should be all right, but like I feel like everyone should do it every year. I couldn't agree more. I feel like everyone should do it every year.
I'm glad that it's not every year. It's still got me. So much that.
Yeah, well, I mean, it's quite expensive.
Yeah.
That's the other thing. Actually, it'll set you back a good £500-600 right now. It's something definitely.
You get that money back if you're trust grade. So apply for trust grade and clinical fellows. They pay.
It depends what trust you're in as well. Some don't pay up north. Okay. This next one is really, really interesting, and it comes back to what Dr. Coogan said. Is the future telemedicine?
Oh, that's it's very interesting, actually. I guess at the height of COVID, we were sort of forced to do a lot of these telephone follow-ups, and sort of we were trying to get sort of video communication and video sort of teleconferencing and things like that. And I mean, if you think about it, I mean, not so much here. Like back in my home country of Malaysia, we used to do a lot of sort of talks, sort of in person. So like, you know, a lot of the this is like for this SMEs, for example, they're actually done sort of in person, and you have sort of like drug company sponsoring and things like that. But yeah, now a lot of it is just done online, really, like just exactly like this. I think yes and no. So I mean, in the sense, like I don't mind telemedicine in the sense, like if it's just more for sort of standard or routine things. Like I said, I think a lot of our GP colleagues, for example, do use telemedicine to make referrals, for example, to dermatology. So patient has like an abnormal skin lesion, they can just sort of show it on video or take a photo of it, and they can just send it directly to the dermatologist via the GP, and then they can even give the advice, or if they need to be seen, or if they need a biopsy, for example. But I think a lot of times, and again, I guess maybe I'm speaking from experience of being sort of GIM/acute medicine. I think seeing that patient face to face, in person, actually examining the patient, because I know a lot do try to examine them sort of via video, which I mean, it's just so tricky, so difficult. But yeah, I think it's that skill which I hope we don't lose, in the sense that if a lot of people are, I guess, moving forward with telemedicine and telephone follow-up and things like that, which I guess a lot of the GPs are being blamed for that now, which I mean is completely untrue. But in the sense, like seeing the patients face to face, I think you need to have that clinical skills, and you need that examination skills to actually diagnose and manage the patient better. Yeah.
I couldn't agree more. Dr. Prab, do you want to add anything on?
No, I think you covered it. I'm not really a strong believer of telemedicine. I really enjoy looking at a patient as a little. But you know, it's the modern world.
It's a tough one. Honestly. I think when I was doing my GP elective this summer, I was there for I think 2 or 3 weeks, and I just felt like a glorified, office worker, because that's pretty much, I think in 2 weeks I got to see maybe 2 patients, and that was really it. So it was a bit of a shock and horror moment. At the same time, I saw how efficient it made the process. So at the same time, you could understand the virtues behind it. I think it's just something a lot of people need to get used to. But at the same time, I feel as if a lot of people do come into GPs and do make appointments for something they really, really don't need to. And I feel as if that's something we've overcame with telemedicine, because very quickly on the phone, you could deal with those people who don't have as much urgency as they think they do, and sort of get that sorted out straight away, and like, okay, go to the pharmacy and get this and get that, and you should be okay. Take care. Plus, if there's any issues, goodbye. And you're sort of that's sort of dealt with. So, but then again, I feel as if you miss something, if you miss a rash, or I think I've been in GP situations before where a patient has came in for something, and the doctor noticed something else. It was a rash of some sort, and they thought it was nothing. So turns out it was quite a bad skin reaction of a sort, and the doctor dealt with that as well. So I think that's something that we're going to definitely miss. But is it the future? I think so. Am I particularly optimistic about it? Maybe not.
That definitely happens in the hospital, where they come in for one thing and they leave with something completely different.
Yeah.
So it's just like pretty much every patient.
Absolutely. We do have other questions, but I think I've addressed the most important ones. So I'm going to leave it there. If any of you guys have other questions, feel free to email them to me, or email them to SME, and they'll forward it to me, and I'll pass them on to the doctors. And whenever they do get time, they will give me a lengthy reply and I will forward it back to you. But again, thank you so much, Dr. Coogan.
Thank you, everyone.
Thank you for being here. And thank you all you guys for joining. I know it's a Sunday. I know you guys are tired, had a long week. So thank you for being here. We really do appreciate it. We will see you next month. I'll leave this call open just in case anyone else wants to access the feedback forms, and I'll probably just close it in a couple of minutes. Thank you all again. Have a great evening. Thank you, doctors. Thank you so much.
Thank you.
Fantastic. Thank you.
Take care. Good evening.